was a horribly smug photograph, wasn't it? I do apologise. So, thank you, Franco, thank you, the organisers. It's wonderful to be back here in Florence. And just from my own perspective, I think as a working group, we're small within the European Society, but we have a major impact. And one of the reasons we have a major impact is because of the dedication and enthusiasm of people like Franco and similar members within our group. So, thank you very much. So, title, Classification of Cardiomyopathies, News for the Future. The wise people in the audience will know that it's always extremely dangerous to predict the future. So being from the island off the edge of Europe, I'm going to start in the past. What are heart muscle diseases? Well, if you go back to John Goodwin's original classification, we haven't, in some respects, moved on very much. Primary heart muscle diseases, not caused by valvular disease, hypertension, coronary disease. There was, soon after he put this particular definition forwards, a slight modification which was promoted by Celia Oakley, which was these were disorders of heart muscle of unknown cause. At this time, the principal way of classifying these disorders was according to the ventricular morphology and function. So if you have a thick heart, hypertrophic, a large ventricle which doesn't contract well, dilated, restrictive, and so on. It was recognized that there were disorders for which some were clearly familial, but we didn't understand the etiology at this stage. And then there were other mimics. You could develop a dilated ventricle if you had coronary artery disease. You could develop a thick ventricle if you had infiltration secondary to amyloidosis. And the terminology that was chosen at this time was so-called specific heart muscle diseases. Now, this approach to classification actually lasted for really quite some time, until sort of the mid-1990s, when there, under the auspices of the WHO, there was a move to modify the classification, largely as the result of the recognition of this entity, ARVD, or as we would prefer now, C, arrhythmogenic right ventricular cardiomyopathy. There were a few sort of minor tinkerings with the terminology at that time, primary cardiomyopathy, secondary cardiomyopathy, but essentially it was the same approach to classifying this group of disorders. Another 10 years or so go by, and there was an increasing feeling that the classification had slipped behind the current knowledge base. Cardiomyopathies, many of them were no longer idiopathic. We were recognizing, particularly from our studies of families, overlapping phenotypes, this concept that you could have the same phenotype caused by multiple genes or the same genetic mutation causing different phenotypes. And of course, this was a very clinical classification. It took no account of our discoveries of the molecular basis of these diseases. And so around that time, there were two approaches, both sides of the Atlantic, where there was a discussion and a debate about how we could advance this very clinical classification into the modern era. In the AHA scientific statement of 2006, there was a discussion about different approaches to grouping these disorders. Could we group them on an etiological basis, Sarcomere disease, desmosomal disease? Should we continue to talk about the pathophysiological abnormalities, predominantly restrictive phenotypes, systolic heart failure? In the end, it was felt that we should try to maintain the distinction between primary and secondary. And primary here actually goes back to John Goodwin's original intention, which was primary was confined to the heart, whereas secondary were disorders that were systemic and happened to involve the heart as part of their manifestations. As becomes apparent, though, it's very difficult often making even that distinction. And if you start then to look at the patients who have primary cardiomyopathies, yes, there are some that are clearly genetic. Yes, there are some that are acquired, but there are some where there are genetic factors interacting with the environment. And one can imagine scenarios that fit this kind of scheme very well, but there are many, many exceptions. In the ESC, we had exactly the same debate. Can we move to an etiological classification? Can we talk about sarcomere protein disease? recognizing that sarcomere protein disease covers many different phenotypes: hypertrophic, dilated, restrictive. Similarly, desmosome, cytoskeleton. And I think if you're a molecular biologist, this approach has many attractions. It does provide some order in the chaos of our recent discoveries. But we felt that the key thing about the classification is who's going to use it? Who are you targeting this classification at? And if you're targeting at this at the clinician, well, it doesn't work that way in the clinic. The patient doesn't present to you saying, "Oh, doctor, I've got a problem with my sarcomere." It just doesn't work that way. What we do is we have a patient who presents with signs and symptoms, and we define a phenotype, and then we move on to the diagnosis. So it was for this reason that, in fact, we didn't really make a great deal of change to the basic structure and the basic philosophy of the classification. We maintain this principle that cardiomyopathies are disorders of the myocardium not caused by coronary disease, etc. But then we said, let's stop worrying about primary and secondary, forget that debate, and instead start thinking about etiology. Because ultimately, that's what you want to determine. Why is this patient's heart thick? Why is this patient's ventricle dilated and poorly contracting? And it was for that reason that we first of all maintained the morphological characterization, but then tried to promote this idea of genetic and non-genetic disease. Because as cardiologists, we see genetic disease every day in our clinics, whether we're talking about heart muscle disease, arrhythmia, coronary disease, vascular disease. And unless you think about it, you miss it. And increasingly that omission is very important because it places family members at risk. Now, of course, it may be very difficult at the initial consultation to make that distinction, but it's important that you start to think that because underneath those categories, genetic and non-genetic, lie a large number of possible causes. So, second aim, raise the profile of genetics in the assessment of these diseases. Now, we also made a few other modifications that didn't create as much controversy as I think we anticipated. The first was this one. So if you see a thick heart when you do an echo or an MRI, that is hypertrophic cardiomyopathy. Okay? You make no assumptions about the etiology. You say the heart's thick, that's HCM. We also hopefully tied it up restrictive. In the previous definition, there were these terms of near normal systolic function, near normal wall thickness. Basically, we said if you want to continue to use that term, it's normal wall thickness, normal systolic function, and a stiff ventricle. So that's where that classification leads you. Long lists of potentially genetic, non-genetic causes of HCM, DCM, ARVC, and restrictive. Now, in itself, that list is not particularly helpful. But what it does is to start you thinking in a different way. It moves you away from this sort of exclusion-based way of thinking towards a much more logical approach to diagnosis. Yes, I've got a long list, but from that list, what is most likely in the patient I have sitting in front of me? And so that leads us, if you like, to part two of this story that we're trying to promote, which is that you see the phenotype, you describe what you see, and then you follow a systematic approach which hopefully leads you towards a likely differential diagnosis. You start with the family history. You start with symptoms, not only, as we were hearing in the sessions this morning, about chest pain, syncope, and palpitation, but about neurological symptoms, muscle weakness. How old is the patient? If your patient is 12, they don't have amyloidosis. If they're 75, they could well have amyloidosis. Gender, again, may influence your differential diagnosis. If you actually spend the time to draw up a family tree, you may get clues. Is this X-linked? Is this autosomal dominant? Is it autosomal recessive? And then you move to your tests. And you interpret your test, your ECG and your echocardiogram and your MRI, and whatever test you'd like to apply, in the context of these other findings. A couple of very brief examples. So you could just look at this MRI along the top. Bit of scarring, quite extensive. Myocarditis, perhaps? Well, in isolation, it means nothing. But if I tell you this patient has a dilated cardiomyopathy, they have a CK which varies between 800 and 1200, They've got this ECG, a classical ECG, with a so-called posterior infarct pattern. Dystrophin is way up on your list of possible etiologies here. And I don't just mean Duchenne muscular dystrophy. I mean the 20 or 30-year-old with Becker's who presents with a cardiac disease 10, 15, 20 years before their muscle symptoms. But you only get the clue when you integrate all the information. There's another one. A gentleman in his 70s goes to the accident department having been assaulted in the street. He feels fine, but someone does an ECG. Actually, before they even do the ECG, some very bright cookie actually takes a proper history and elicits he's had bilateral carpal tunnel syndrome. He's got ECG, yeah, maybe a loss of R waves, late transition, has an echo, and he's got largely asymmetric hypertrophy. The posterior wall is a little bit thickened. So what is the diagnosis? Well, he has an MRI, because that's the gold standard, and the MRI says, well, it's a little bit of gap, but not sure what this is. Right age, carpal tunnel syndrome, hypertrophy. What do? We did a bone scan, of course. Bone scan? Why do we do a bone scan? Because it's an exquisitely sensitive test for TTR amyloidosis, which you already knew was going to be the diagnosis. Very patchy, posterior septum. And then we did a biopsy and confirmed the diagnosis. So what I'm trying to do here is to show you that the classification is not an abstract concept. The classification provides you with a tool, a schema, on which you can lay good old-fashioned clinical acumen using all of the information you have available to you. Now, if you're a taxonomist, you say, yeah, that isn't a classification. I'm very sorry. A classification is the classical, if you like, Linnaean approach. We want a hierarchy here. Okay, well, if you want a hierarchy, then you've got to get modern too. How about that for a hierarchy? Okay, so we're moving away from Linnaean classification. We're now using molecular genetics to classify species along phylogenetic lines. And you can do this not only with species, but you can do it, if you like, with proteins. So here you see the family of myosins organized in a phylogenetic tree, which is extremely useful if you're a molecular biologist. If you're trying to determine, for example, whether a variant is actually genuinely occurring within a conserved residue. But is it useful to you as a clinician? And the truth is, you don't want just one classification. You need classifications which suit the task in hand. So if you're a geneticist, you'll need one. If you're looking at proteins, you're another. If you're a clinician, you'll need a different classification scheme. So don't be wedded to any one scheme. There's no one answer to everything. But use it as a tool. And if you have the tool, then we can start to move on and ask about the domande importanti. Grazie mille.
So one important point is that we are used to define familial and non-familial, our patients and their family history. But are we sure that they are non-genetic when they are non-familial? Can you comment on that?
Yeah, so that's why we use that slightly tortuous way of phrasing it, familial or genetic versus non-familial, non-genetic, because obviously it could be a de novo mutation. So the absence of a family history, for example, or even the absence of disease in screened relatives, parents, does not exclude the possibility that you're dealing with a genetic disorder. So that's why we phrased it in that way.
I fully agree with the photo.
It's horrid, isn't it? It really is horrid. Yeah.
Second point, do you think we should already update the classification? Should they already, as a working group, already work on it and refine it a little bit? Say non-compaction. I believe that if you go and watch the term, in which we have defined the restrictive cardiomyopathies, a little bit nebulous, and above all, one of the topics that was attracted most of the big discussion was amyloidosis in the context of hypertrophic cardiomyopathy. So, do you think that we should, after, and I fully agree, of course, of the classification that we produced, do you think it's time to, refine a little bit?
Assolutamente no. That's what I meant. That's why I put that final slide. Ask the big questions. Does it really matter if we define what the threshold for end diastolic pressure is when we're defining restrictive cardiomyopathy? Does it really matter about non-compaction, which is something we can't quantify anyway? What really matters is the patient, about prognosis, diagnosis for a family. And I think that acts as a tool. Non-compaction is a very good example. How do you use that information? If you see genuine non-compaction, that tells you already that you're probably dealing with a genetic disorder. So the key thing is that I think I'm dealing with genetics, not is it a ratio of 2.1 to 1 or whatever. That isn't important to me. It's important about diagnosis, treatment, and prognosis. So I don't want to go back to that.
May I also ask, I take your point completely about the way the patient presents, and as clinicians we need to treat the patient as a patient and then to go through a differential diagnosis. But once you've done that, looking at the difference between the European versus US classification, would you still call it hypertrophic cardiomyopathy if a patient has amyloidosis or some other infiltrative process causing thickness?
Sure would.
Because in the European classification, that still fits under the diagnosis of the category of hypertrophic cardiomyopathy.
It does. You describe what you see. So for me, hypertrophic cardiomyopathy means the heart muscle is thick. Otherwise, you tie yourself up in knots. I'm only going to call it hypertrophic cardiomyopathy if it's sarcomere protein disease. But I don't know whether it's sarcomere protein disease until I've done the test. And then if it's negative, and I haven't got evidence for amyloidosis, do I call it unexplained LVH, or I've just not done enough genetic tests? It's an irrelevant question. The most important question is to say, what is the cause here, and what is the relevance to this individual patient?
Because well, I don't disagree completely, but one's treatment certainly would differ depending upon whether it's sarcomeric hypertrophic cardiomyopathy or an infiltrative process.
But that's why I did the second part, though, because it provides you with the framework, and then what's important is how you use that framework to construct a diagnostic pathway.